Okay guys, finishing up our fetal anomalies, and last but certainly not least, we are going to be talking about all of the abnormal development of the fetal skeletal system. So we learned really early on this semester that the ossification of the skeletal system happens really early on, earlier than a lot of people anticipate. So by about 10 weeks gestation, we pretty much have every major bone group at least started to develop really early on in that pregnancy. So we have a lot of these anomalies and these conditions that kind of pop up really early on because it is such a primitive system that starts to develop as early as it does. So one of the first terms that we're going to talk about is dactyly. Now, dactyly is kind of like a root word, meaning you can have different variations of it. So we have polydactyly, we have oligodactyly, and we have syndactyly. Dactyly is talking about the relationship of the digits. So when we have an extra digit, an extra finger, an extra toe, we're going to call that polydactyly. When we're missing one, we call that oligodactyly, kind of like our amniotic fluid, right? Polyhydramnios, too much fluid. Oligohydramnios, not enough. And then syndactyly is when we have the appropriate number of digits, but they're going to be abnormally fused together. Dactyly in all of its forms are going to be very common, but we see them associated a lot with some other chromosomal abnormalities, especially syndactyly, where we get that fused digit together. You can see that on the right-hand side there. Now, polydactyly, where we have the extra digit, this is kind of like an isolated finding. It's kind of just like a random occurrence. We don't really see it occur too often with a lot of chromosomal abnormalities, where we usually do with oligodactyly and syndactyly. So these people are usually just born with a little extra thumb or a pinky or a little extra toe hanging off their foot. So that's going to be on the left-hand side. You can see that they have 6 fingers there, an extra pinky. And then oligodactyly in the middle, that left hand is missing 2 digits. Okay, moving into actual skeletal conditions. So the broad term that we give for skeletal abnormalities or anomalies is going to be skeletal dysplasia. This is kind of like an all-encompassing term. So we kind of break it down further based on the type of skeletal anomaly and really what else is going on along with that. So skeletal dysplasia is just stating that there's abnormal growth and density of the skeletal system. So the cartilage can be abnormal, the bone can be abnormal, both can be abnormal. So really kind of just giving it that broad term. Now we're going to see some sort of skeletal anomaly in about 3 out of every 10,000 births. So that seems like it's not that common, but it actually really is. So we're seeing some variation of a skeletal abnormality very commonly in the real world. There are right now over 450 types of skeletal anomalies, so 450 variations of some type of abnormality happening with your skeletal development. And then we have some further subterms here. We're talking about melias. So we just talked about dactyly in reference to relationships of the digits, and now we're talking about melia. This is when we are talking about the length of a extremity or a length of a bone. So melia is just talking about bone length. Rhizo is saying that we have a shortening of a specific proximal bone. Meso, we have a shortening of the middle segments of the bone. And micro is when we have shortening of the entire extremity itself. So let's take a look at what that looks like when you're saying like, oh, we'll come back to this slide. When you're saying, oh, shortening of the proximal bone versus the middle portion of the bone. Up at the top here, we have normal relationship of this arm or this extremity. So our proximal bone is going to be our humerus. Our distal bones are going to be our radius and our ulna. Now, when we have rhizomelia, we're saying that the proximal bone is abnormally shortened. So this is going to say that our humerus is shorter than it should be. Mesomelia, the distal aspect of the bone is shortened, or the middle segment of the extremity is shortened. The hand would technically be the distal aspect. So the middle segment of the extremity is shortened. And then micromelia, both segments are going to be shortened. So if this were the leg, we would say that rhizomelia would be where the femur is shortened. Mesomelia is when our tib fib is shortened, and micromelia would be when all of those bones are shortened. Now let's go back here. So skeletal dysplasia, like we said, broad term, so many different types of variations and subcategories of it. Very common, unfortunately, in the real world. This is kind of what we are going to see when we're talking about a baby who has a skeletal abnormality or some sort of anomaly with their skeletal development. Now, each of these babies, if you look at their skeletal radiographs underneath them, if you look closely at them, you notice kind of differences between each x-ray. But if you're kind of looking at them quickly, they all represent very similar characteristics. The babies have very like protruding torsos. Their arms are really, really short. Their legs are really short. Their heads are very big and round. So these are going to be kind of those classic sort of fetal appearances when we're talking about dysplasias. This is not talking about one type of dysplasia. This is kind of just showing that although we have so many different variations of skeletal dysplasias, they're all going to sort of resemble each other. They're all going to be closely related with their own differences. Okay, so getting into some of the common dysplasias. Our first one is thanatophoric dysplasia. And I remember this one from Marvel movies. If you like Marvel movies, you have heard of Thanos. If you don't like Marvel movies, he is a Greek god of, I believe, death or destruction. And that is going to be kind of what this condition is. So this is going to be the most common lethal skeletal dysplasia. There are two different types of this thanatophoric dysplasia, but both of them are going to be incompatible with life. They have a very severe effect on the spinal development and on the cranial development, and these babies cannot survive with this condition. Type 1, we're going to be able to identify skeletal anomalies are very easily identified on ultrasound. Whether or not we can pinpoint the precise variation is up for interpretation, but we can kind of use the knowledge that we have of each of these types of thanatophoric dysplasia to maybe help us if we were to see these. So type 1, we're going to see femurs that are short and bowed. We're also going to see very flat vertebral bodies. So those spine pictures are going to be very, very important. And then type 2, we're going to see straight femurs, so they're not going to be curved like in type 1, but they're still going to be short. We're still going to see the flat vertebral bodies, and then we're also going to see a clover leaf skull. So here we can see the picture on the left-hand side representing a curved femur. This would most likely be type 1 of thanatophoric dysplasia. And then we can see our clover leaf skull on the right-hand side, which would represent type 2. And again, it is not our responsibility to precisely pinpoint these conditions, but we do need to make sure that when we are taking our anatomic pictures during an anatomy exam, that they are precise and they are accurate so the radiologist can compile all of that information to aid in a diagnosis and hopefully get them the genetic testing that they need. So we just said thanatophoric dysplasia is the most common lethal skeletal dysplasia, but then we also have achondroplasia, which is the most common non-lethal skeletal dysplasia. So this is going to be when we have a decreased amount of endochondral cells during bone formation. So the very structural cell of our ossification centers, we don't have enough of it. So we basically aren't really going to ever fully develop our skeletal system to the extent that we need it to. This is going to be mainly caused from advanced paternal age. So an older father can be a risk for this condition. And then it is going to be a genetic thing. So we can have, again, guys, genetics, DNA, all of that stuff. Not in my wheelhouse at all, but you can get this from either one parent or both parents. If you inherit this from one parent, it's a pretty good prognosis in terms of like complications if you have this from one parent, versus if you get this from both parents, it's very strong genetics. You're going to have more complications along with that diagnosis of achondroplasia. So achondroplasia in and of itself is non-lethal. These people go on to live a very normal life. But if you happen to inherit this from both parents, that's when we run into more medical complications down the road for those patients with achondroplasia. On ultrasound, we're going to see rhizomelia, we're going to see macrocephaly, very large head, trident hands, which we haven't talked about yet, but this is very common in the skeletal world. It's when we have very, very short fingers. So we have a short phalange in our fingers, or really both phalanges in our fingers, and our palm kind of stays the same size, but then we get like these little like tips for fingers. We're also going to see a depressed nasal bridge and frontal bossing. So not to be confused with an absent nasal bone. An absent nasal bone is going to be indicative of trisomy 21 and other trisomies or chromosomal abnormalities. Although this is a genetic condition, this is not going to represent an absent nasal bone. A depressed nasal bridge is we're not going to see it protrude as much as we normally see that nose protrude on a baby. And frontal bossing is going to make that depressed nasal bridge look even more prominent. So when you have that really large forehead coming through and you have that sunken in nasal bridge, it would be very easy for you to say that there's a missing absent nasal bone, when in reality, the nasal bone is there, it's just sunken in more. So here's going to be the typical appearance, the physical appearance of somebody with achondroplasia. Now these are all children with achondroplasia. You can kind of see that they have that rhizomelia of both their arms and their legs. Their humerus and their femurs are both very shortened. They have very large heads, that frontal bossing in that profile view in picture B, that depressed nasal bridge really kind of coming in towards their like eye cavity. And then you can see the trident hands down at the bottom there. Their palms look appropriate size for a baby's age, but then the fingers look very stubby and kind of just like little tips hanging off of the palm. Next, we have achondrogenesis. So achondroplasia, most common non-lethal skeletal dysplasia. Now we have achondrogenesis. This is a lethal dysplasia. Not the most common, because the most common would be thanatophoric dysplasia. But now we're kind of continuing on some of those dysplasias that are going to be a little bit more worrisome. So achondroplasia is kind of like, all right, you're fine. You know, don't really need to worry about that too much. But a little variation from achondroplasia into achondrogenesis, totally different story, different situation. So this is going to be a rare lethal skeletal dysplasia. We're going to see abnormalities in the cartilage that are going to result in abnormal bone formation and also not being mineralized enough. So the bones are going to be very weakened as well as being abnormally formed together. On ultrasound, we're going to see severe micromelia, so that's talking about the entire extremity itself. We're going to see decreased or absent ossification of the spine, and that's because we have that hypomineralization, right? We don't have enough mineralization going on during ossification to create that really strong bone in the spine. We're going to have macrocephaly, a short trunk, so we're going to have a very kind of compressed thorax and ribs. We're also going to see micrognathia, that abnormally small chin, and polyhydramnios. And these are going to be representative of different variations of achondrogenesis. Now the baby on the left-hand side, not really anything too crazy that's sticking out right at you, but if you look at the baby's head, that head is going to be abnormally enlarged. And then if you also look at just the overall brightness of their ribs and their spine and even their extremity bones, they look very dull. They don't look bright white. They don't look radiopaque, as we say on X-ray, the way that bones should look, especially in a baby. Now the picture in the middle, picture on the right-hand side, pretty obvious that there's something abnormal going on. Picture in the middle, you can see all of those bones in the extremities. They are so short. This baby does not have a spine at all. Abnormal head shape and development. Same thing with the baby on the right-hand side. Those bones are like gray. Again, no spine or any sort of structural skeletal development going on in that trunk. So very sad. Next, we have osteogenesis imperfecta. So I like to reference anything I possibly can to a movie. If you've ever seen the movie Glass, this is going to be what he had. So I think it was, what was it? It was the sequel to Split, where he's in the wheelchair and he's like ends up being like a really bad guy. He like commits all these crimes and he's like wheelchair bound, and everyone's like, how does he commit all, like, how is he so bad if he like literally can't even get up out of a wheelchair? It's a great movie. But he had osteogenesis imperfecta. So this is going to be a very rare condition, but it's going to be very, very severe. So basically, these babies have specific genes that result in not having strong enough bone formation. So there's not enough collagen, there's not enough cartilage, hypomineralization. There's really nothing in terms of substance to their bones. So it's known as brittle bone disease. And there are 4 classifications to this. The classification system is a little bit bizarre because classification 1 and 3, 1 and 4 are going to be considered more mild, whereas this should say 2 and 3 are going to be lethal. So these babies die shortly after birth from that trauma. But category 1 and category 4, pretty mild. We're still going to have brittle bones. These children are still going to experience numerous fractures throughout their childhood. They're going to be a little bit shorter in stature than they normally would be, but they're not going to have any sort of like physical appearance characteristics like achondroplasia, achondrogenesis does. So these kids may look developmentally normal in terms of their skeletal system, but their bones are going to be like paper thin. They break, even if you cough too hard, they break multiple ribs. So these babies are very, 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 very sensitive. They basically need to be like protected at all times, because even if they're in their wheelchair and they hit a bump, on the floor, they could get a fracture. So it's very severe, and these children have very hard lives ahead of them. And again, if it's category 2 or 3, these babies just cannot survive after birth. On ultrasound, we can see fractures in the long bones. So when we're taking our femur images, when we're taking our calf views, our radius and our ulnar views, we'll be able to actually see disruptions in that hyperechoic bone. They're also going to have a narrow thorax. We're going to have micromelia in some of the extremities. And then, of course, we're going to see that hypomineralization of the bones themselves. So they may not appear as bright and hyperechoic as we're used to seeing. So here's going to be the femur, and you can see those multiple disruptions right along that long bone. And it's like this baby could not be any more protected. This baby is in utero with amniotic fluid, a placenta protecting them, a mom protecting them, and this baby is still getting multiple fractures in their femur. So it's very unfortunate. Next, we have congenital hypophosphatasia. So quite a mouthful here. This is going to be, again, another lethal condition that these babies just cannot survive after birth. We have that hypomineralization caused by a deficiency in terms of their alkaline phosphatase. So I'm not expecting us to go back to like biology with any of this stuff. I don't expect you to know like what alkaline phosphatase is and like what the endochondral cells do and like thanatophoric dysplasia. Like, just know that this is the cause of these conditions. We don't need to get too crazy into like the why. This is going to appear very similar to osteogenesis imperfecta and achondrogenesis. On ultrasound, we're still seeing that hypomineralization of the bone. We're going to see micromelia. We're going to see fractures in the long bones, maybe even completely missing extremities or abnormal looking extremities. The head is going to appear hypoechoic as well. Those cranial bones are not going to appear nice and hyperechoic. And then we'll see a small thoracic cavity. So here we are placing all of that together. Pictures are a little bit blurry, but you can kind of get the overall view, especially from the head picture and the spine picture, so B and C. You can really see like how poorly dense these bones are. The cranial bone, we want to see it, especially at this age gestation. Like, this baby looks like it's at least 20, 25 weeks gestation, and we're not seeing that bright white skull. We're not seeing that bright white spine in picture C. That's going to be the takeaway. You don't want to adjust your controls to the point of making it look like they're actually ossified properly. Like you don't want to turn your gain all the way up to make it look like they're nice and bright white. You don't want to have your gain set so low that a normal baby skeleton looks like it's hypomineralized or looks like it's less dense than it is. So you want to make sure that your settings are appropriate and that what you're seeing is actually what you're getting, or what you're getting is what you're actually seeing. And then picture D, it's showing us the small thoracic cavity. Picture A is of the abnormal extremities. Next, we have dystrophic dysplasia. So again, another rare condition where we have multiple things going on. We're going to have micromelia, talipes, which we will talk about, cleft palate, which we've already kind of mentioned before, micronathia, scoliosis, short stature, and earlobe and hand deformities. So earlobe, I don't really know of anyone who's taken a picture of a baby's earlobe before, especially on a routine anatomy exam, but everything else is pretty much going to give it away. So we're not going to miss hand deformities. We're not going to miss cleft palate. We're not going to miss the abnormal relationship of the foot with talipes. We're not going to miss micromelia. We may miss an earlobe deformity, but all of the other conditions that go with dystrophic dysplasia, we're not going to miss those. This is going to have a variable prognosis. So most people with this, as severe as those anomalies or abnormalities are, have a pretty normal lifespan and pretty normal neurologic development. So their intelligence, their lifespan, pretty normal, but it all depends on the severity of all of those abnormalities that are associated with it. On ultrasound, we're going to see all of those things. We're also going to see an abducted thumb. So that means it's being pulled away from the hand. It's like hyperextended. It's like a super hitchhiker thumb. We are also going to see that scoliosis, micronathia, cleft palate, micromelia, everything else that is associated with this, we will be able to see. And here's a baby with classic dystrophic dysplasia. Again, looks super similar to achondroplasia, right? Pretty large forehead, micromelia, you know, achondroplasia is more so like rhizomelia, but still like micromelia in that sense, shorter stature, so pretty similar in appearance. Oh, and then this is showing that abducted thumb. So look how far away his little thumbs are being pulled from the rest of his fingers. Next, we have short rib polydactyly syndrome. This is not a dinner that you can order at a restaurant. This is going to also be lethal. The baby has exactly what we're saying: short ribs, short limbs, and polydactyly. So everything is short. There are 4 primary types, but we do not need to know that. Just know that there are 4 categories that go with short rib polydactyly syndrome. On ultrasound, we're going to see a narrow thorax with those short ribs. We will see the polydactyly. We will see the shortened extremities. And we could also see a midline facial cleft. So if you haven't noticed by now, a lot of these anomalies have like, we'll be sitting there like going through like the ultrasound appearance or like the, you know, the abnormalities that are associated with it. And you're like, oh, okay, that makes sense. Oh, that makes sense. That makes sense. And then you're like, and an abducted thumb. You're like, where does that come from? Like, where does a midline facial cleft come from when everything else we're talking about is the baby having short ribs and short extremities? So that's just like how closely related the whole skeletal system development is super early on in utero. Because this system develops so early, we are going to see abnormal development of kind of secondary systems related to it, if that makes sense. Oh, and here we have our baby with our very short ribs, narrow thorax, short extremity bones. So pretty unfortunate. And if we also kind of think about why short rib polydactyly syndrome would be lethal, if you kind of just look at that thorax, does it look like their heart is going to be able to function properly? Does it look like their lungs are going to be able to function properly? I think it's pretty safe to assume that that's no. So we also have some additional skeletal syndromes that you do need to know of. You do need to know these 3 conditions, but it's not really something that we see too much on ultrasound. It's something that's going to be done through genetic testing, but your registry will ask you about at least one of these 3, if not give you a multiple choice with like these all being an option, so you have to know these. Roberts syndrome is going to be a genetic disorder where we have limb and facial abnormalities. June syndrome is going to be when we have thoracic dysplasia, so the thoracic cavity is so poorly developed that the baby is basically choking on itself, so we have asphyxiating thoracic dysplasia. Camptomeliac dysplasia is when we have a group of lethal dysplasias that are characterized by bowing of all of the long bones. So all of the long bones are going to be bowed, and that includes the ribs as well. And then all of these are going to be lethal. If somehow a baby does survive, they're going to have severe, severe developmental abnormalities, and it's going to be a pretty hard life for those patients. So they're going to have severe handicaps, impairments, developmental issues. It's really unfortunate seeing these babies with these sort of conditions. Moving down to the foot. So this is something that is very important for us to make sure we know how to document properly on an anatomy scan. So yeah, the foot pictures are super cute. Everybody loves those. One of my favorite pictures of the little baby feet, but we take those images for a reason. We're looking for the relationship of the foot to the ankle. If we see an abnormal relationship of the foot to the ankle, that can indicate a congenital or a genetic abnormality, or it can kind of represent some sort of restriction in utero for that baby. So either way, we need to figure out why there's an abnormal relationship of the foot to the ankle and the calf. So we have clubfoot. Everyone has probably heard of this before. It's also known as talipes equinovarus, or usually just talipes. It can be genetic, like we said, so a genetic condition commonly associated with something else, or environmental. Now, if it's environmental, we're talking about the environment that the baby is in. So if the uterus is too small, they have restrictions in utero, not enough amniotic fluid for the baby to kind of stretch and extend their feet. Amniotic band syndrome, where a portion of that amnion comes loose and is now free floating in the amniotic fluid and can very easily wrap right around the baby's body parts. Or if the mom has a uterine tumor, a fibroid of some sort, that can all kind of cause these restrictions that kind of create this abnormal relationship of the foot to the rest of the ankle and the calf. 55% of clubfoot deformities are bilateral, so that's going to mean that most cases are going to be genetic. Usually if we have an environmental case of clubfoot, we're only going to see that on one side. On ultrasound, it's all going to vary depending on the severity of the relationship from the foot to the ankle. So we're really kind of looking at the angle of that relationship, the degree of that relationship, and we'll very easily be able to pick clubfoot up if we are looking in the right plane at that baby's leg. So here we have the elongated calf. We can see the tibia and fibula elongated, and now normally we wouldn't want to see the anterior aspect of the baby's foot when we have the elongated calf. So in a normal baby, we would see the elongated calf bones, and then we would see the baby's foot like this, like looking down that way. So we can see kind of look like bird's eye view onto this baby's foot, that degree of angulation from where it should be. Next we have rocker bottom. So this is technically a type of a clubfoot deformity, but it doesn't necessarily mean that there's an abnormal relationship or angle between the foot and the calf. It's talking about when the bottom of the baby's foot, so the plantar aspect of the baby's foot, kind of bows outward, and we almost get like this extra little padding of soft tissue underneath the baby's foot, and it makes their foot look like a rocking chair. So this is going to be associated with trisomy 13 and some other chromosomal abnormalities. Here we can see that thickened sole of the baby's foot, really kind of pushing outward and convexing outward. It's cute, but we don't want that for our baby. Next, we have sandal gap. This is known as hallux varus, another really big registry question. Make sure you know what that term is. Make sure you know the difference in terms between talipes, aka clubfoot, and hallux varus, aka sandal gap. Sandal gap is literally going to be exactly what it is. There's an extended space between the big toe and then the second toe. This can be a normal, isolated, kind of random occurrence, but it's usually going to be associated with other abnormalities as well. And just finishing up here, we can kind of see that space right between that big toe and the first toe. So very discreet. Again, feet pictures are super cute when it's a baby, but it serves a bigger purpose. So we're looking to see, okay, what are the relationships of everything going on? What does the soft tissue look like? Are there 5 toes? Are there 6 toes? Are there fused toes? Fusion can be a little bit hard for us to identify on ultrasound. Syndactyly can be a little bit hard for us to see because all of that tissue is so small anyway, and the babies usually kind of keep their hands and their feet curled, so it's hard for us to see if there's any sort of separation between the fingers and the toes. But usually if we see something as obvious as this picture here, we can kind of say or assume that that's going to be a scandal gap. So a lot of new information. We haven't really talked about a lot of this stuff prior to this. We will definitely kind of be coming back to this a little bit when we learn about our genetic conditions and more specific trisomies. If you thought that these dysplasias were random in terms of the sonographic appearances and variations, just wait until we get to trisomies. It's like absent nasal bone, polyhydramnios, and like clubfoot. I'm kind of just like pulling that out of my head, but there is such a wide spectrum of what is seen with trisomies that we really can't piece it together. It's kind of just these random occurrences that you have to remember them for what they are. So we will get to that with our next module, but if you have any questions with this one, please reach